Good evening and welcome everybody to the National Keratoconus Foundation evening webinar. I'm Dr. Gloria Chu and I have been your moderator for almost the last 2 years and will continue to be for the next 2 sessions. I practice at the USC Roski Eye Institute in Los Angeles, California, and I'm an optometrist. And tonight I have the pleasure of introducing you to 2 amazing optometrists. I'm going to start with Dr. Karen Lee. Dr. Lee is going to be the moderator starting this September 2023. She will be taking over for me after my 2-year course of being with you every other month during these wonderful evening webinars. And you're going to be very, very lucky to have her. She's really an amazing person, friend, optometrist, and keratoconus specialist. She received her Doctor of Optometry degree from Indiana University School of Optometry and completed a cornea and contact lens residency at the Southern California College of Optometry. And that's where we actually connected because I completed my residency there. Prior to joining the University of Houston as a clinical assistant professor, Dr. Lee served as director of the Specialty Contact Lens Clinic at the University of California, San Francisco Ophthalmology Department. She is currently a fellow of the American Academy of Optometry and the Scleral Lens Education Society, a fellow of the American Academy of Optometry and the Scleral Lens Education Society, but also served as past president of the Scleral Lens Education Society, and she is currently a GPLI, or the Gas Permeable Lens Institute Advisory Board member. So thank you, Dr. Lee. We look forward to having you on board for the next 2 years. And now we will turn our attention to our topic and speaker for tonight. We have the amazing Chantelle Mundy. I'm going to give you some background on her before she gives her talk. She is a clinical associate professor at the Ohio State University Department of Ophthalmology and Visual Sciences. She's a graduate of the Ohio State University College of Optometry and completed an ocular disease-based residency at the Cincinnati Eye Institute. She's the program director of the Cornea and Contact Lens Residency Program and clinical instructor for both optometry and ophthalmology residents, optometry students and ophthalmology residents. She's a fellow of the Scleral Lens Education Society and a fellow of the American Academy of Optometry. Dr. Mundy is the co-founder of the Advanced Specialty Contact Lens Clinic in the department, and she received the 2022 Top Doc Award from the National Keratoconus Foundation. Her title and topic for this evening is Risk Factors for Keratoconus. So just a couple reminders, please feel free to enter any questions that you may have in the chat box. Those will be moderated for the first time tonight by Dr. Karen Lee. And I am going to turn it over to Dr. Mundy. It was wonderful seeing all of you. I will be back for our next webinar in July. So I'm going to turn it over to Drs. Lee and Dr. Mundy for tonight. Dr. Mundy?
Yes, thank you, Gloria and Karen and Mary at the National Keratoconus Foundation for inviting me this evening. I'm very excited to speak on risk factors for keratoconus. So I'll just go ahead and get started. I have no financial disclosures. Make sure. There we go. And I just really want to do an overview on keratoconus and the risk factors associated with development and progression, and those are multifactorial. So we're going to discuss genetic factors, environmental and lifestyle factors, and potentially their role in implicating the detection and the progression of keratoconus. So we'll start by just defining keratoconus. I think this is important always just to remember that keratoconus is bilateral and asymmetric disease, and it results in progression and thinning and steepening of the cornea, leading to irregular astigmatism and decreased visual acuity. And it's important to define irregular astigmatism. It really means as your corneal shape changes and becomes more cone-shaped or irregular, we're unable to correct this astigmatism with conventional contact lenses or glasses. So it's requiring us to do more specialized contact lenses to improve your vision. And why is it important to identify these risk factors? Well, historically, we knew keratoconus was estimated to be about 1 in 2,000, but we know now that the number is much higher. And when you look at prevalence rates, and it varies depending on kind of your geographical location and ethnicity, with the highest prevalence being in the Middle East and Asian. And there was also a study in the Netherlands recently that reported there was keratoconus for 1 in every 375 people. Now, this was a little different type of study where the mean or average diagnosis was at 28 and 60% of these patients were males. So it really varies across different studies on the prevalence rate. But when we look at those as a whole and kind of collectively on the whole population, we can now say that it's closer to 1.38 per 1,000 people that have keratoconus. So when we're looking at these risk factors, why is it so different? Why is the prevalence rates so varied across studies? Well, in the historical studies or the previous studies, our diagnostic capabilities were limited. We did not have the tools or the advanced technology that we do today to detect and diagnose keratoconus. We really just had our microscope. We would look under the slit lamp and see, is there any changes to the cornea? And we know that in the early stages of keratoconus, we might not see any of these changes or signs of keratoconus. There was other methods such as retinoscopy and other detections, but still that's very limited. We now have measurements that are more sophisticated, such as tomography or topography. And these are important devices to help us monitor the curvature and the thickness of the cornea. And when you look at those colors represented on this map, those are really the high and low points of the corneal tissue, with reds and oranges and yellows being higher or steeper areas, and the greens and yellows being flatter. Now, this is an example where we're looking both at the curvature of the front part of the eye, kind of the topography, but also when we look at tomography, we can look at the thickness of the cornea, which we can represent a map of how thin certain areas and if it's changing. So why is it important to, again, identify the risk factors? Because we want early detection and timely intervention. We now have the ability to halt progression of the disease. And if by halting the progression of the disease, we can maintain vision correction options. And this in turn prevents more aggressive treatment options as the disease progresses or complications. So when we talk again about early detection, we really want to halt progression. We know the one way that we can halt progression, the only way, is with corneal collagen cross-linking. And this is a procedure using a combination of riboflavin and UVA light to induce the cornea to stiffen and prevent changes. And importantly, this procedure requires a minimum corneal thickness. And when we're monitoring and identifying patients at risk, we want to watch the thickness of the cornea to maintain a certain amount, because if it goes below, in our protocol, 400 microns, which is a number we're always monitoring, then patients are no longer a candidate for this procedure. So monitoring closely if your cornea is at risk is extremely important. So identifying those risks is valuable in monitoring. So what are the other importances of identifying the risk factors? Well, of course, detecting and stabilizing the cornea. And this also gives us the ability to have more options for vision rehabilitation, such as glasses or contact lens options. And with all of my keratoconus patients, I want to briefly go through this short glasses versus contacts and why do glasses not work as we get more advanced stages. Well, in the normal corneal shape, you can see that blue curve, that very front part of the cornea, is nice and regular. And as light passes through the glasses, you can see it can then be moved through that cornea and focused into the back of the eye with a 1 point. But if we have glasses with an irregular cornea, or when the cornea becomes more cone-shaped, it actually, as it touches that corneal surface, can distort and move the light into different areas. So again, that's developing that poor quality of vision that we know, which is the halos, the double images, and that blur that develops and limited in glasses. But when we have keratoconus patients beyond glasses and we need to move especially contact lens, this is sometimes why we need to do it, because we need to cover up that irregular curve so light can first hit the contact lens and bypass the irregular cornea in most cases to help focus better at the back of the eye. So if we have more options to do that, in halting the progression and identifying that. We can find the right contact lens easier and sometimes have more options if we're preventing the progression of that. And when we talk about contact lens options, I just want to briefly talk about a few and divide them into categories. One, and the first one being soft contact lenses. You can really think about those as conventional, which are just kind of the off-the-shelf regular contacts, and then the custom options. And those really mean we have to specifically order you the prescription that you need, whether that being toric to correct high amounts of astigmatism. There's even keratoconus specific soft lens contacts that are designed to be thicker to mask some of that irregularity on the cornea. In most cases, as keratoconus progresses, we need to use a rigid gas permeable material. And just to make it simply, we can divide it into corneal or scleral. With one, we're fitting an RGP or a small lens onto inside the cornea. And with a scleral lens, we're actually not touching the cornea and we're resting all the lens edge entirely on the white part of the eye, which is the sclera. We also can have a combination of the two, being hybrid and piggyback. And so with hybrid lenses, those are actually, I know we recently had a webinar with the Keratoconus Foundation about hybrid lenses specifically, but those are one lens combined with a soft peripheral outer skirt, as you can see in that top picture, where you have that very edge of the white part of the eye. And where you see it glowing kind of green, that's the hard center. We also have potentially a reason you might need two lenses on the eye, and that's called a piggyback system. So that means a soft contact lens is worn and then an RGP or a hard contact lens is worn over top. We do this for a couple reasons. Sometimes we do it for the stability. If the lens is moving around too much, we want to cushion that and help stabilize it, so we'll put the soft lens underneath. We can do it to help with comfort. So in case the patient is noticing too much movement of the lens and that's discomfort, then that can help. It also can help protect the cornea by adding a little extra cushion. So there's multiple reasons that we use a piggyback, and sometimes we have to do that if we're not able to move to other lens designs and there's just some issues with the RGP. So if we have patients that continue to progress and we don't identify risk factors and detect this early, patients can develop corneal scarring. And you can see on this picture where the arrow is pointing, kind of that hazy part of the picture, that's the scarring that's actually in the corneal tissue, right below the pupil. And depending on where the scarring is, it can lead to vision changes and problems or limitations when you're wearing your contact lenses. And so that can lead to further issues with vision correction. As keratoconus progresses, we can also have the potential complication of corneal hydrops. And then corneal hydrops, what happens is that the cornea thins to the point that there's a layer that breaks, and that allows the fluid that's inside the eye to rush into the corneal tissue and cause swelling. And this happens in about 2% of cases, but either direction it can happen is it can resolve on its own. So over time, that swelling can decrease, the cornea can scar down and actually flattens the cornea to some degree to make it easier with some contact lens options. Or it can be so extensive that the swelling does not resolve, or it creates a scar not below the pupil, but kind of in your line of sight that you potentially might need surgical intervention. And this is what we're trying to avoid. It's, again, a corneal transplant. And you see the black kind of lines, those are stitches, that's the actual transplant. But again, as we try to detect and halt progression and identify patients at risk, we're trying to avoid further progression and into the point of surgical intervention. So when we talk about risk factors this evening, I just really want to kind of put them into 3 different categories, one being our environmental risk factors, the second being genetics, and then potentially other related conditions. And when we talk about environmental risk factors, we can talk about different types such as HP, allergies, and eye rubbing. And we're going to go through this briefly. But when we talk about HP, what we're really saying is a condition associated with an inherent or genetic predisposition to develop allergy. So if you look at different studies, it's actually difficult because it's defined differently and throughout the studies on what is HP and is it more risk. But essentially, it's your immune response against common allergens. And this can be not just the eye, it can be skin, such as dermatitis, your respiratory tract, rhinitis, your lungs with asthma, and then again, conjunctivitis, which can happen in the eye itself. And when we look at the overall relative risk, patients with asthma have a 1.9 times more risk, allergy 1.4, and eczema 3 times more risk. So within HP, that definition itself can be challenging looking at literature, but then when you separate those out, we know between asthma, allergy, and eczema, there is increased risk. And just to briefly touch on what happens when our bodies experience an allergy and what potentially can connect with these pathways. One is something called IgE. And IgE is an antibody that's, when you're exposed to an allergen, you have an immune response. So your body recognizes it as foreign and it produces these IgE antibodies. So that level goes up. It's almost like a glitch in our system. We recognize something, whether that be pollen or pet dander, and it then produces this antibody. So it triggers this response. And then after you produce those antibodies, those trigger then an allergic response, which are chemicals such as histamine and mast cells, all these chemicals that will then trigger a chemical, the chemicals lead to inflammation. And that inflammation is going to be that itching and the redness and the swelling and potentially mucus production that you create. And there has been reports in keratoconus patients, the incidence in elevated levels of IgE, has been between 52 and 59%. So there's, this pathway that is elevated and triggered when we have an allergic response. And particularly in the eye with allergies, that we can have allergic conjunctivitis, which is either seasonal or perennial. And when we talk about itching, I just want to say this response is natural. This is a line of defense. This is our body telling us to remove the allergen. So rub your eye, remove the allergen. And then the same thing with tearing. It's another line of defense where the body is trying to wash out the allergen from the eye, so removing it. The swelling is there because the body is moving fluid to the area to block and move the proper cells to help. And the redness is due to your blood vessels widening to be more efficient for the cells to move to that area. So this is the response and why it's happening. And, particularly when you experience allergies, this is a common presentation. This is actually one of my scleral lens patients that has terrible seasonal allergy. So this, even though he's wearing a scleral lens in this picture, has not related to the scleral lens. Actually, he's just having a really bad allergy flare. In addition to just our regular allergic conjunctivitis, there's something called a vernal keratoconjunctivitis, or VKC. This is actually a more severe form of allergic conjunctivitis. It's common in children, so especially young males in tropical countries, but it can occur into adulthood. The inflammatory response is higher, so there's increasing potential complications because of this, and also because of the recurrence. So we think about this happening especially in children where they're potentially, having a more intense inflammatory response and for a longer period of time. So there was a study that looked in VKC versus just the regular seasonal allergic conjunctivitis, and what they found, it's in a younger age and there's actually more severe keratoconus that was associated. This picture is actually one of my patients that is a picture of underneath the eyelid. So it can develop all of those large kind of bumps that you're seeing is one of the responses or one of the signs when you have a patient with allergies or VKC. It can also lead to, in addition, more problems with the cornea, such as scarring. So there's more implications when there's more severe inflammatory response. So what makes severe ATP, ocular allergies, VKC, more linked to keratoconus? Well, short answer is we don't particularly know, but we do know that eye rubbing is one of the most important risk factors for keratoconus. And I'm going to say that again. One of the most important risk factors for keratoconus is eye rubbing. So the overall risk of developing keratoconus was 3 times higher in subjects who had abnormal eye rubbing on a daily basis. And so when we talk about abnormal eye rubbing, there really can be kind of different ways that we define it. It can be the hand palm compression where you're actually pushing your palm in. It can be the knuckle massage where you're kind of using your knuckles and rubbing. It can be just your finger poking, but all of those do not help. It can cause problems. So it's across studies, abnormal eye rubbing is defined differently, but we know from the CLEC study too that there's a 50% patients reported eye rubbing, and there's more significant difference in corneal changes in patients that report rubbing only one of our eyes. So there's lots of studies that report eye rubbing. And what we think about eye rubbing, it's more of a pathway that potentially causes or worsens keratoconus. So the vigorous eye rubbing is more common in allergic conditions. And potentially we're causing microtrauma to the corneal tissues in addition to inflammatory pathways. So we don't particularly know, but we know that it's a high association and across the board as we study that it's one of the major risk factors. So when you have allergic conjunctivitis or you're having allergies, it's really important to discuss this with your eye doctor. You want to make sure you're managing your symptoms to stop the eye rubbing, or make sure you're managing it to the best of our ability. So following up with your doctor, and the treatments can depend depending on the severity. So it's making sure that at first you're eliminating your exposure to the allergen. That can be number one if you know what's causing it. If you're feeling, poorly with a lot of inflammation, a cold compress can help with the symptoms. Artificial tears can be helpful just because especially if you put them in the refrigerator, you can get the same sensation, kind of that cold feeling, instead of rubbing your eyes using artificial tears. Just removing the allergen off of your eye, so potentially using an eyelid wipe can be something that's utilized. Sometimes a drop is needed, and that can be either antihistamine, like a mast cell stabilizer drop, or even a steroid eye drop if it's needed, if it's severe. Now, even with that being said, with all these things we can manage, we potentially still might not be able to manage all of your symptoms. I'm very lucky at OSU because we have the allergy department essentially is really close to us, so we are able to kind of co-manage patients and work as a team. And that's true across the board, not only for our allergists, but also with our cornea specialists. We really try to, I think it takes a team to manage this. But when we send patients for allergy consults, it's really because we either want to investigate what's the potential cause, or we can't control it with those methods. And that may lead to another therapy, like immunotherapy may be necessary. For example, I had a patient that we had very severe allergies, and we had tried all of those methods. And so I sent her for an allergy consult, and the result was that she's allergic to cats. And so unfortunately, she lives in a very small apartment. She's unable to avoid the allergen, so she's then now on immunotherapy. So she's, for a period of time, getting allergy shots. But then that in turn might be needed to help manage those symptoms. And the other thing, with your own children talking about eye rubbing and allergies, you really want to make sure that if you have a family member or you have keratoconus and you're noticing the eye rubbing with family members, siblings, children, you want to make sure you educate them not to do that. So it's sometimes we don't realize that we're doing it in ourselves. So making your family aware that's something you shouldn't do. My little girl right now experiences really severe seasonal allergies, and she knows not to rub her eyes. And she's only 6, but she's learned how to put in her allergy eye drops, because we try to talk about how important that is so we remember not to rub our eyes. I'm going to switch really quickly to genetics. So we know that keratoconus is a multifactorial disease. So there's multiple factors, not only genetics, there's environmentals, but within the genetics, there's multiple genes. So instead of it being one gene, like for example, if you have a trait such as that you can roll your tongue, if you have that gene, you're able to do it. If you don't, you're not. It's not that simple. And the inheritance pattern, how it's passed down, is also not straightforward. So it can make it very difficult to research and to pinpoint certain genes that cause keratoconus. So we know it's polygenic. That means 2 or more genes, are needed or are required in most cases, or present in keratoconus. But that being said, we know with familial incidence, there's an estimated, the relative individual with keratoconus has a 15 to 67 times greater risk than a person with no family history. So having a first-degree relative with keratoconus is one of the most significant risk factors. So when we talked about earlier eye rubbing, but then we talk about genetics, having a relative with keratoconus is one of the most significant risk factors. And first-degree relative means it's your sibling or child or parents within that. So there are, we talk about genetic testing, how we're trying to investigate keratoconus and evaluate keratoconus potentially is also genetic testing. There's Avogen is a genetic test that assesses the risk for keratoconus. It's not conclusive. It'll give you a polygenic risk score, low, moderate, or high. And it's looking at 75 different genes that were associated with keratoconus. So this is involving a cheek swab, so it could be used with children, or family members. It's also looking for other corneal dystrophies. But I did want to highlight, there's potential if patients are, talk to your doctor if you are interested in this. With related conditions, there's some associated medical conditions that we know, one being Down syndrome. I'm going to talk about sleep apnea, and then a few of the connective tissue disorders. I'll start with Down syndrome. We know that Down syndrome is the most common genomic disorder, with 1 in 700 live births, 6,000 per year in the US. And keratoconus across, if you look at the different studies, there's actually a reported range of prevalence from 10 all the way up to 71%. And now that varies depending on the patient population where the study was done, but we know overall it's higher in Down syndrome patients. And this can be thought to be due to potentially a thinner cornea. It's associated with eye rubbing and atopy in most cases, and sometimes, depending on the severity of the Down syndrome, uncontrolled eye rubbing, and so that can be difficult to manage. Also, these patients frequently suffer from blepharitis, and what blepharitis is, it's an inflammation of your eyelids, and that can lead to itching and eye rubbing as a result. It's important for this population to identify the risk factors or know that they're higher risk so we can detect this early. We want to make sure, if at all possible, to halt progression, because sometimes it's difficult to manage with our contact lens options. Just like every patient I tell that wears contact lens, no matter what type of lens and what material of the lens, you want to make sure you really accomplish 4 things. And one of those is being able to safely remove and apply the lens, either yourself or a family member able to help you. The second thing, obviously, it's got to help improve your vision and being able to know that it's helping your vision. The third is it's comfortable and stable on the eye. And the last thing is that your eye stays healthy wearing the lens. So there, within those 4 things in the Down syndrome patient population, we can have multiple challenges in accomplishing that to be successful. So really identifying, knowing the risk, and monitoring these patients is extremely important. When we talk about connective tissues disorders, Ehlers-Danlos syndrome, this is essentially a connective tissue that provides strength to the joints, the skin, the blood vessels, and the organs. And it's a connective tissue disorder caused by genetic mutation. So it's in the structure of the collagen. So it's a multi-organ system involvement. And so we know with corneal thinning, there's 13 different subtypes, and it's reported in 3 of those subtypes. So most of the time with keratoconus, 97% of the time, it's only involving keratoconus, but 3% of the time, it can be involved in all these different conditions, these multi-system conditions. In addition to EDS, there's also Marfan syndrome, which is another connective tissue disorder. This is caused by, again, mutations in specific genes, and not only affects the eyes, it can affect your cardiovascular and your skeletal system. So these patients can have additional problems. I did want to have a representative photo. This is another one of my patients, does not have Marfan syndrome, but something that can happen differently is that they can have what's called lens subluxation, where you can have the lens that's inside the eye, actually, because the tissue is not strong enough to hold it, it will actually drop or sublux down, and they can have issues from that. It's been reported that cornea is flatter, but also thinner in Marfan syndrome. And I want to switch now to sleep apnea as a related condition, and I think this is extremely important for people listening tonight and recognizing some of these risk factors with sleep apnea. Overall, with sleep apnea, there's 2 different types. There's obstructive sleep apnea and there's central sleep apnea. You can have one or the other, or actually a combination of the 2. And obstructive sleep apnea, it's essentially what it sounds like. You have obstruction in your airway as you're sleeping, that it's going to inhibit you from proper sleep. With central sleep apnea, it's really more neurological. It's related to your brain. But for this talk, we're going to talk about obstructive sleep apnea, because that's really involved in keratoconus. When we talk about the prevalence of obstructive sleep apnea, it's estimated at 14% of men and 5% of women, and actually those numbers can be even higher because of some of the undiagnosed patients. And the really important thing to remember with sleep apnea is if it's untreated, there are severe risks, and that involves your cardiovascular disease, difficult to control blood pressure, congestive heart failure, and stroke. So it's really important to know if you're experiencing any symptoms as a keratoconus patient of fatigue, headache upon awakening, those classic kind of sleep, deprivation symptoms, that you discuss your symptoms with your family doctor or even your eye doctor. I have referred patients for sleep studies and sleep consults. We know in keratoconus patients, they are 1.8 times more likely to have obstructive sleep apnea. The exact mechanism is unknown. There's potentially an increase in enzymes which break down cells with obstructive sleep apnea. There can be eye rubbing during sleep. You're more likely to sleep with your hands near your face or sleep on your stomach. And we know sleep position is potentially a risk. So if you're actually pressing on your cornea and sleeping one side or the other, either pressing on your arm or something, that's actually pushing mechanically onto the eye. When you have sleep apnea, you have hypoxia, or you can have lack of oxygen to the tissues, which can cause tissue damage. So these are multiple different kind of thought processes on why this is happening and what the association is. We also know floppy eyelid syndrome is associated with sleep apnea and then in turn keratoconus. And if you see this picture, when you see the patient or the doctor raise the patient's eyelid, you can see all the upper aspects of the globe and even underneath the eyelid. So if you can lift the lid and see all of those structures and actually lift the lid, and sometimes it'll even invert or flip inside out just by pulling up, that can be floppy eyelid syndrome. And that's really lax eyelids, and that can result in symptoms such as chronic papillary conjunctivitis, more irritation. So in turn, knowing that that's associated with both sleep apnea and keratoconus, as we are talking about risk factors. So I want to go through some other considerations as well, just when we talk about risk factors. And one is firstly diabetes. It's not reported as a significant risk factors. And if you look at different literature, and some of it's actually reported as protective, meaning, if you have diabetic, there's less chance of keratoconus. And this is thought to be potential changes in the corneal fibers. So if there's, the pathway or the mechanisms are there's elevated glucose and there's some cross-linking type effects, but overall it's not reported as a significant risk factor. When you look at the studies when it's comparing men versus women, there are some studies that show there's some higher prevalence in men, but when you combine all these studies together, it really looks like it affects both equally, men and women. I do want to highlight contact lens wear as well, because it's been reported to trigger the development of keratoconus. This was in a paper in 1978, so it's an older paper, but it's important because we use contact lenses to manage keratoconus. So it's unlikely, as we look across, to be from contact lens wear alone. We know there potentially are other factors, such as eye rubbing, associated conditions like dry eye with your contact lens wear that can lead to more eye rubbing. So it's not as simple as just wearing contacts. There can be influences on your cornea from contacts, but from the literature, we know it's a combination of factors. We know it's important to have a properly fit contact lens because there's 3 times more incidence of corneal scarring with your contact lens versus no contact lens wear. So that in turn, it's important to have good management of your contact lens and your contact lens wear. As far as UV exposure, this is a challenging one because there's been reported higher prevalence of keratoconus in countries with greater sun exposure. So this could be due to oxidative stress. But when you look at the actual studies and the research into it, is it related to ethnicity? 2 studies kind of conflicted, and basically what the result was, there's more research needed to determine kind of the UV exposure and that risk. We also have the ability to think about thyroid. We know there might be some involvement with hormones, so potentially thyroid hormones, particularly hypothyroidism. And there was a population study in Germany, found an increased risk of prevalence in thyroid gland disease in keratoconic population versus general population. So again, looking more into that as far as a risk factor. And then in pregnancy, we also know hormonal changes during pregnancy can affect the corneal thickness and the biomechanics of the eye. And so over, a pregnancy, this can result in progression. So if you are pregnant and you're noticing changes in your vision, you want to make sure that you're reaching out to your eye doctor and letting them know. And lastly, I mentioned blepharitis earlier. But blepharitis is also something that we need to pay attention to in regards to keratoconus. It's inflammation of the eyelids. So that could be related to bacteria or other skin-related issues, but your common symptoms are burning, irritation, tearing, and redness. So there's a higher prevalence of blepharitis and keratoconus, and it could be associated with eye rubbing that maybe contribute to the progression. So as with allergies, if you have been diagnosed with blepharitis, it's important to follow the guidelines for management. And some of those guidelines that we have are eyelid hygiene, and that can be different products and different ways to clean your eyelids. Sometimes we use a warm compress first, and that helps loosen up some of the debris. And what I mean by that, if you look below the arrow, you can kind of see that yellow appearance, and that's a collection of debris that kind of gets matted onto the base of the lashes. And that in turn can lead to irritation, more areas for the bacteria to grow. So you want to make sure that you're cleaning this with the proper methods. And your doctors can recommend different methods, but ultimately warm compresses and different products to close the eye and actually massage gently, removing that debris with different types of recommend products is important just to manage your symptoms. So overall, just to kind of summarize, family history is one of the most important or strongest risk factors for keratoconus, but we also know environmental factors such as frequent eye rubbing can also potentially cause increased risk. So it's important to make sure that you're not rubbing your eyes and you're telling your family members not to rub your eyes to prevent problems or progression. Certain medical conditions are linked, and particularly like we discussed sleep apnea and recognizing that as a potential problem. And overall, we know understanding risk factors for keratoconus can help individuals and us as healthcare providers to help manage and improve our outcomes. And as we look into the future and we have more research, maybe these models are going to be more specific on our risk factors. To date, we just want to make sure we recognize those that have the highest risk. I just want to thank you, and this is my, our team in the Advanced Contact Lens Clinic, and I could not take care of my keratoconus patients without my staff. They're amazing, so I did want to highlight them tonight as well.
Thank you, Dr. Mundy, for a great talk. I feel like I learned so much on that. We got a bunch of really interesting questions that I'm excited to ask you right now.
Oh.
So one of the things you mentioned when you were talking about your Down syndrome patients is making sure that your patients can put the lenses on safely, right? And I completely agree. I think most of my patients in clinic probably struggle with that the most. Do you have any tips or pointers for patients that are struggling to put their lenses on or take them off?
I really think we work hard. Like I said, my staff is so important with helping me and with the training of that. And I think some of the pointers, I think what I tell patients a lot is we don't expect you to be able to do this well at first. It will take time. So sometimes it takes repeated trainings. And I know that's hard to do, but if patients go home and they're successfully putting it in, all of a sudden they can't. Sometimes it just takes us watching them. There can be something small they're doing that if we just change and modify that, they'll get it. So not giving up is one thing. Helping utilize, your eye doctor and your staff to kind of guide you through some of those. We definitely have tools and tricks with different devices. We have stands, we utilize stands for patients. We have guidelines. And I will tell you, especially, patients, such as Down syndrome, I definitely lean on caretakers, family members, spouses, whatever that may be, to not only teach the patient, but also teach them as well. So I don't know if there's one across the board trick. I think it takes everyone working together to be successful with it, to make sure the patients are, we're giving them the best they can do, best try.
Yeah, I completely agree. I think I've had one patient come in for 5 different sessions for trainings. And then at some point, there are a lot of really helpful scleral lens tools out there, whether it's what's your problem? Can you not see the lens, or are your fingers just, very shaky? And so understanding that there's a lot of tools out there, whether it's a stand or the sea green light adapter, talk to your doctors and just tell them what you're truly struggling with, and they can send you down that path.
Right, exactly.
So one other thing, if you had a patient and they were like, Dr. Mundy, what is the one thing that I should do to just decrease my risk? Because I can't change my genetics. I can't move out of this, location. What would you say to them?
I honestly still think that eye rubbing, that would be my first thing. You know, I actually recently had a patient, long-standing patient, scleral lens wearer, that was kind of lost for follow-up for a period of time, and came back to me recently after having, you know, she lives a little bit further away, but having severe allergies. Her cornea progressed 10 diopters because she'd been, you know, I see it clinically all the time. So even in my existing patients, you know, I really try to make sure that we're understanding that if there is a problem with eye rubbing, and try to recognize that if we can help manage and treat that, because that is one of the our major risk factors that we know. Because we can't change our environment sometimes, right? We can't change, our genetics, but that definitely is something that we can control and manage.
Yeah, 100%. I think there was an interesting study where there was like a video of an MRI showing a keratoconic patient rubbing, and it was literally just like knuckle.
I know, the knuckle rub, the hand, it's really, can be really intense, and people don't know they do it sometimes. Honestly, I don't think people realize it. It's just part of it's like a habit. It's not something that they're realizing.
And there's some patients with keratoconus where their allergies are so bad that they're already on the orals and the drops.
Yeah.
And at some point, I just tell them like, hey, when you are desperate to rub, keep a bag of frozen peas in your freezer.
Something cold. Yeah.
Yes. And then instead of rubbing, just slap the peas on your face, and everyone just knows like that bag is not for eating. That is for me not rub.
Yeah, the artificial tears. I do tell people that too. Like, but it's hard to, if you're at home, but right, if you're kind of out and about, it's a difficult thing. And also just, I know this is simple, but like if you have seasonal allergies, like washing, like coming in and, washing off the, removing your clothes. I mean, I do this with my little girl if she's outside playing, and I know when she comes in, her eye's going to be puffy and red, and she's going to want to rub it. Remove the clothes, make sure you're washing some of that before that even starts.
When it comes to the different types of contact lenses and the progression of risk, do you feel like one lens over the other has less chance of having risk progress for a keratoconic patient?
Oh, this is kind of a challenging question. I think I get by the time they come in my clinic, a lot of times we're at the point they're so advanced that I have to do a scleral lens, that nothing else is going to sit on the eye. But then I have this group of patients that cannot apply a scleral lens. And so, they're in these RGPs and they come and they're just completely rubbing and, causing more problems. And so, yeah, I don't know. I think it depends on each situation. As far as like, do I feel like one is causing more problems? I think it depends on what's going on, for that particular patient. But a lot of times, I move patients at this point to more sclerals where we're not even.
100% agree. I think, shockingly, even in clinic now, I will still occasionally get referrals come in where they say like, oh, my doctor told me that if I am in a flatter fitting lens, I can push my corneas back to keep it from progressing. Thankfully, we have completely learned that that is not true. And I agree. A majority of my patients are in sclerals as well. And some patients actually come in specifically asking for iPrint Pro. And so, do you have any thoughts about that type of lens?
I do. I'm an iPrint provider here, so I actually find it very valuable because when we have referrals for the really extreme cases and advanced cases, I give it's another. I think about it in levels here. We kind of are able to level up on what options we can do that manage the patients, especially the ones that are so advanced that they're kind of teetering on the transplant. And we know even with this really advanced eye, we can get 20/20 with a scleral as long as we can, use the iPrint technology. It has been kind of, for us, we've been since 2017 a game changer in some of our patients that really require it. I recently had one that was more pellucid, and it was just an extreme case, or like, somewhat of a keratoglobus where the whole, it's very valuable for those advanced patients. Yeah, so I utilize that in clinic.
Yeah, and so, I think the biggest difference that patients probably should understand is it helps with those advanced cases, because iPrint Pro is the one where like putting that blue goop in a little martini glass and actually taking a mold of the eye. So the fitting process is so different, but that lens is really truly custom for you.
Yeah.
Like,
I think the hard part, about contacts is, we try to have a lot of options here because not one lens is the fit all. Like not one lens takes care of every case or every patient situation, and not one lens works on each eye. I mean, we have all kinds of different combinations really tailored to what that patient needs and what the eye needs. And so when we have, even iPrint Pro has limitations if you can't get the impression, and we use prophylametry, which is scanning systems where we can get, more customized lenses, but if you can't get the scan, so you really have to have a lot of different layers and levels to kind of help manage it and think outside the box on how to get a good impression or a good scan or a good diagnostic fit to make it successful for patients. So we work really hard to do that.
I think one common misconception is patients come in and they're just like, I've tried all the lenses, none of them work, like let's do surgery, and I never need lenses again. What do you usually say to those patients?
I usually tell patients, I usually tailor about 60% to 70% of people after a corneal transplant still come back to me needing a specialty contact lens. So I do educate them when we get to that level, especially if their problem is they can't get the contact lens in. That is a big education because there's, if they have a transplant, there's still likelihood that they're going to have to move in that direction. So I try to do a lot of patient education along with our cornea specialist. I think the team approach that we have here is pretty special. So we kind of all try to work together to educate that, and they're good about communicating that as well.
Yeah. And every now and then you just have like a few patients who maybe they just have incredibly strong genes, because even after a transplant, like their keratoconus can almost come back.
Absolutely. Yeah.
Surgery. Yeah.
And there's some, after cross-linking studies, talk about like still progression and, is it related to eye rubbing after, cross-linking? I mean, there's some other studies that are talking about that, but yeah, that is definitely something that you can see happen.
So now that we mentioned cross-linking, right? Outside of cross-linking, do you know of any like vitamins or nutrition that can help prevent risk of progression?
No, that was actually, I was looking into it prior to this talk because in the last, I think 1 or 2 webinars ago, that there was like a debunking kind of myths about keratoconus, and he did mention, nutrition, because even looking at studies, I think there needs to be more research and is nutrition involved? Where is that? And, supplements, obviously. I don't recommend at this point any supplements or discuss nutrition as a component of changing a care or care plan with patients based on the literature, but obviously we need to do more research and kind of find that information for patients.
100% agree. So essentially not enough scientific literature to really back that up, but of course, the healthier you can be, the the better lifestyle, hopefully.
Right. Yes. I do say that, just a healthy diet overall. I mean, that's going to help our eyes no matter what, and our whole body. So yeah, I do talk about that, but no particular supplement at this time do I recommend.
If your patient has family members that have keratoconus, but they themselves, for the most part, seem like they were lucky and spared, do you recommend those patients get genetic testing for it?
I know, it's if the patient requests it, but we still monitor them very closely. There's still initial intake we actually don't see pediatric patients here. So if they have younger children, then we'll refer them out. We have a children's hospital and the College of Optometry pediatric clinic close by. But if the teenagers, and especially those, then we kind of always make sure that we're educating and getting them evaluated and having the tomography and the serial kind of monitoring. I don't know, I guess, how about you, Karen? Do you recommend genetic testing at this time?
So I very much similar, but actually had a patient today, one of my favorite patients, come in. His mom and one of his siblings, I think he said his brother has keratoconus. He himself is not diagnosed with keratoconus, but we continually measure that corneal curvature. So the tomography with the pentacam, we repeated it, and I'm just really carefully looking for changes as well too. Thankfully, no changes. He just had the scan done today, and the last time he did it was January. So we're doing it pretty frequent just to make sure. And he's in his 20s already. So usually I'm more concerned, I guess, if they're on my radar are younger.
Oh yes, absolutely. If you start to see changes, we know that it changes more quickly in a younger with pediatrics. And so I'm usually, we're talking with the cornea specialist pretty early on if we think a family member comes in and brings their child and I see anything going on. So we want to be aware of that. And the younger we find keratoconus or we can detect it, we want to make sure those can advance pretty quickly.
Yeah, agree. I think the youngest patient I saw with keratoconus was like age 9, even though they kind of think it starts around puberty. I feel like we're definitely seeing it earlier and earlier.
Right, for sure.
For someone that has sleep apnea and keratoconus, is there anything that can be done for that patient?
I think making sure that they're working with sleep medicine. I really am a big advocate when I have patients with sleep apnea. Actually, I have family members that have severe sleep apnea and had some major complications. So I think it's just close to my heart in addition to that. But, we have that discussion and I feel, a lot of times I also bring it up multiple times if they delay in getting the sleep study or the sleep evaluation, because it's that important, not only for the eye. So can it be done? I think you need to make sure that if you have severe sleep apnea or you are a person that has sleep apnea, that you're getting the management with the CPAP and you're wearing your CPAP. And to avoid complications, and the sleep position to me is interesting too, because I know just from family members how they sleep on stomach and it's on the eyes pressing on either side or it can favor one side, and some of those studies report sleep position. But yeah, as far as anything that can be done, I think making sure that you're really advocating for the patient to get evaluated is important.
Yeah, I love that you mentioned about the eyelid flipping, because I feel like when I was younger on the playground, there were some kids that could flip their lids and then they chased you around and now you're like, oh my gosh. And it's really true. Like you just take, for all of you in the audience, if you just kind of pull real hard, if you find that that lid just flips really easily, you might want to talk to your doctor about sleep apnea. You never know.
Be really impressive, as you lift your lid and you don't realize how far you can actually see. You shouldn't be able to do that or flip your lids as you lift your eyelid.
Exactly. We have a lot of abbreviations in optometry. So one of our audience members actually asked, what does RGP mean that was used in your lecture?
Oh yeah, rigid gas permeable. So that's a contact lens. It's a hard plastic material.
Yes, exactly.
We abbreviate it for lots of, there's lots of different types of plastic and different designs, but it's kind of our abbreviation for rigid lens.
Perfect. Someone else asked, do we think that there's going to be a better technology that comes out in the future besides scleral lenses?
I think thinking about just even the last 5 to 7 years with the advancements in customization, I really think that we're going to continue to get better and better at designing things to fit on the eye for more advanced cases. The customization, I think we're going to continue to go. I always joke with my students, my residents, if I could have an impression-based, scanning-based, all combined 3D lab in my clinic, that's kind of like down the line, what could we do that we, could make something right there for someone with all these technologies combined? That would be amazing. But, who knows? I really think that we are still getting better at both, designing it, but also correcting the optics. So with higher order operations and incorporating that into how we can really improve, lens designs and vision. As far as detection, I don't know what you think, but just, I think the biomechanics of the eye, and as we're looking into some of those devices like the Corvus and some of that work, I think that's very interesting to think about, risk factors and how we can develop that kind of guidelines for patients as we get more information here, with that. So that's, those 2 ways, yes, I do in some ways think we're going to get better as we continue to get more advanced technology.
Yeah, I agree. I know sclerals are here to stay. My hopes in the future are we can detect keratoconus earlier in our patients.
Absolutely.
And then cross-link all of them when they show signs of progression, and then hopefully just keep them from even needing to go down that transplant scleral lens route. Right now, what is the most common reason you feel like patients don't get cross-linked when you refer them out?
I think some of them, as much as we try to, indicate the importance of it, I think the education, especially, what the National Keratoconus Foundation is doing about educating, but just educating our patients, because if they get lost to follow-up or they don't come back, or they're scared, sometimes even just, apprehensive about it, and then they reach a point that they're not a candidate. That's one of the worst feelings, so you want to make sure you're doing your best job and getting them to that appointment or communicating with cornea, working with cornea so they can potentially get it. There's also some insurance implications, I think, sometimes with getting coverage. I think that's getting better though with regard to insurance coverage.
I think Glaukos is working really hard to get epi off cross-linking onto like more payer panels and whatnot. And then, I've also heard from my own patients where they have to advocate for themselves with their insurance. So, after all that's said and done and they've already paid for the procedure, getting all the notes and the bills and just submitting it to the insurance so that they can get reimbursed on their own, and just having an advocate, I think, has played a really big role in their condition.
And it's true. You do have to do that. And we have a person, I think, that's really helpful, that specifically her whole job is, prioritizations and helping specifically for cross-linking. So as far as like, I think improvements, both, advocating for yourself and working with people like who we have, those types of people that can really help you along the way. It's really helpful, important.
Yeah.
That's the same with contacts too. I mean, my people that help me get authorizations for, we built a lot of programs to help people in financial need too. And our people that help both on the insurance side will help patients on that end too. So I think my staff is so valuable, and those people especially, I really appreciate.
So one last very interesting question. This audience group is very inquisitive. So someone just asked, as a person ages, is eye rubbing less detrimental?
Less detrimental. So we know the cornea stabilizes as we get older. So in the younger person, we know that it's going to progress more quickly. We see that, second decade of life. I still think we should not rub our eyes no matter what age you are. I think, whether it's less detrimental, I don't know. I would say that, but I would say still, no matter what, I would not rub your eyes, because even though we say we don't progress, I have still seen it happen clinically too in patients that are older. So I say no eye rubbing.
I'm on the same boat as you. I agree. I've had patients come in where their sclerals looked great the year prior, and they're in like their 60s or 70s, and then shockingly the fit completely changes. And then when we do the corneal curvature scan, like they definitely progressed. Who knows? Maybe they'll change that definition of, slows down in your late 30s and 40s now that our method of monitoring progression has improved.
Right. Yeah. So no eye rubbing, no matter what age.
Agreed. Well, thank you everybody for staying on with us today. Dr. Gloria Chu will be back in July for the next webinar. And of course, thank you so much, Dr. Mundy, for an interesting talk. Had a lot of fun. Just kind of getting to chat with you at the end here too.
I know, it's good to see you, Karen, as always. Thank you, everyone. Appreciate it.
Is there like another slide or anything like that?
Oh, I'm so sorry. Yes, can I there you go. Okay.
With the next topic. Oh, there we go. Okay, so July 11th, addressing keratoconus vision needs throughout life with Dr. Gels and Dr. Greenstein and Peter Hirsch. And then of course, Dr. Gloria Chu will be back to moderate. Everybody have a great night. And thank you, Mary and the NKCF for sponsoring all of this. Bye-bye.